So I'm Ward Holder. We're very excited about this first webinar of the year. And we're going to take a little bit longer just to let people get settled in and get ready to hear. All right. Again, I'm Ward Holder. I have the honor of being the director of the honors program at St. Anselm College. This year, our honors lecture series is concentrated on the life that we are all living. It is about living in the era of COVID-19. And our first lecturer, we wanted to go to one of the signature programs at St. Anselm College, our nursing program. And we have Professor Carrie MacLeod. And it's my honor to introduce her. Professor Carrie MacLeod is an assistant professor of nursing at St. Anselm College. She taught at St. Anselm briefly before finishing her doctorate, as well as serving as an adjunct professor in the William F. Connell Graduate School of Nursing at Boston College. And then she returned after completing her studies. Professor MacLeod not only teaches in the nursing program at St. Anselm, but is also a proud alumna. After her Bachelor of Science in Nursing from St. Anselm, she did master's and doctoral degrees in nursing from Boston College. Professor MacLeod draws on a wealth of practical experience in her teaching and research. She served as a staff nurse on the medical surgical unit of New York University Medical Center, a staff nurse on the cardiac surgery intensive care unit of the New England Medical Center, a nurse practitioner at the Department of Cardiac Surgery at the West Roxbury Veterans Administration Hospital, a nurse practitioner in the Department of Cardiothoracic Surgery at the Leahy Clinic, and a nurse practitioner in the Department of Cardiac Surgery at North Shore Medical Center. She's also widely published. She has co-edited with Kathleen Perrin the second and third editions of Understanding the Essentials of Critical Care Nursing, published by Pearson. She's contributed chapters to these volumes on the care of patients with heart failure, with acute kidney injury, and with the management of dysrhythmias. She has published articles both jointly and solo authored in journals such as Nursing for Women's Health, Nursing Critical Care, Nursing Science Quarterly, and Nursing Research. Tonight, Professor MacLeod's lecture is entitled Nursing in the Time of COVID-19. We encourage those of you who wish to ask questions of Dr. MacLeod at the end to use the Q&A function, and we'll be able to address those at the end of her lecture. But for right now, let us welcome Professor Carrie MacLeod.
Thank you so much. It's my pleasure to be here. And I'm very honored myself to be starting this year's honors lecture series. When Dr. Holder approached me in the summer to talk about what would be a good topic for nursing in the time of COVID, I really wanted to focus on sort of the emotional and psychological impact that this pandemic has had on nurses. And I will say, as I talk through this presentation, although I'm focused on nursing, a lot of these issues are for all healthcare providers. My lens is a critical care one, as you can tell from that introduction. I've worked as an ICU for years as a nurse and as an acute care nurse practitioner. And as a nurse educator, I teach critical care to my students. I'm in the ICU with my students currently at the Elliott Hospital. And we're seeing a lot of changes. So I thought it was maybe a good idea to take some time to reflect on how the pandemic has impacted nurses, take some time to think about it. And for those of you who are not in healthcare, maybe have you gain an improved understanding as what nurses and healthcare workers are going through during this time. Certainly a product of St. Anselm College. And I would say that the technologies and skills that I was taught many years ago, much different than what we're teaching our students now. but the philosophy behind what we teach our students remains the same. We really look at nursing as an art and a science, and the ability to provide compassionate care in a holistic manner. I'm going to switch over to my presentation, and when the presentation is done, it's about 30 minutes, I'll come back on. I'll be happy to take some questions or some discussions. So give me a minute while I switch screens here. Okay. So nursing in the time of COVID-19. Let's get this to advance. Here we go. I'm just going to move this up out of the way. All the things that I've learned to do in this new world order here. I want to take a minute to acknowledge that a lot of the black and white images that you're going to see during this presentation are from a website called nurses.dearworld.org. And that reference is on the reference slide at the end. I would highly encourage everyone to take a look at this website. It's provided a forum for nurses to talk about their personal experiences of taking care of patients with COVID and also their own experiences having COVID. I also decided when I was going to prepare for this presentation to perhaps reach out to those individuals who are taking care of patients during the peak of the pandemic. So nurses being nurses, I reached out to my peer group, and nurses being nurses, they all got back to me very quickly with a, what do you need? What can I do? When do you need it? So there are 5 women in this presentation that were generous to share some of their experiences, and I'm going to share those with you. As we go through this presentation, I want you to have a better understanding of some of the issues that existed in nursing prior to the pandemic, how they were exacerbated during the pandemic. Think about ways that we can support our nurses, and how do we prepare our new graduates to deal with this? Now, here at St. Anselm, we teach nursing as an art and a science. And I think we're going to be good to go from the science perspective. We're going to teach our students the skills they need to do whatever we need to do to take care of these patients. It's the art that has me a little concerned, that ability to provide compassionate care in a whole different environment. And it's not that we're not going to try to do it, but there's going to be some barriers. And I think we need to address those. I went on the CDC website this morning just to take a look if there was any uptick in the numbers of healthcare workers who have died because of caring for patients with COVID-19. And it hovers about in the mid-600s. And a lot of professional organizations really question that number. They think it's underrepresented. But even if it is a little underrepresented, 1 is too many. And that 1 is too many is a very big deal for someone that has to go into the front lines every day to take care of the COVID population. Just to give you a little bit of a background about issues in nursing. Now, I'm a qualitative researcher. I like to have a topic of interest and sit and talk with people who are involved in that topic of interest or research interest, hear about their feelings, their emotions, their experiences, and then across those individuals, extract themes that sort of capture big evolving themes across everyone. In nursing and in qualitative research, these are for the top research topics: moral resilience, moral courage, moral stewardship, moral distress and injury. This is a really hard place to leap off when you have a pandemic encroaching upon a profession that really struggles with these issues. I did a literature search while I was preparing for this presentation, and I just typed in moral distress in nursing 2020, and I had over 7,000 hits. That's incredible. But what is moral distress? Because that's what I want to focus on, and preventing it from growing into moral injury, and having a better understanding of how this pandemic can make that happen for many nurses. So moral distress is really knowing the right thing to do, but being in a situation in which it's nearly impossible to do it. It's a complex, very challenging problem, and it can have damaging repercussions. And until most recently, it was often ignored in the healthcare environment. As a matter of fact, the American Nursing Association has a code of ethics, and one of its provisions says that nurses are ethically bound to care for themselves. It is, and I quote, "The nurse owes the same duty to self as to others, including the responsibility to promote health and safety and preserve wholeness of character and integrity." And because of the gravity, the complexity, the frequency of ethical challenges that have accompanied this pandemic, moral distress is evolving into moral injury for a lot of nurses. It's not just the little things that build up. There are critical life and death decisions involving triaging and rationing of care multiple times a day. What are some of the challenges that we're facing? Well, there's shortages of life-saving equipment, and everyone saw in the news the need for ventilators, for dialysis machines. With the surge of patient admissions, we just don't have enough to go around, nor do we have enough ICU beds. The lack of personal protective equipment. Now, I know in this pandemic, you've probably learned a lot of abbreviations you never really wanted to know, and PPE is probably one of them. That lack of personal protective equipment is necessary. It's necessary to protect themselves, to protect their patients, their families, and their communities. There can be difficulty maintaining or the maintenance of moral equilibrium. When you're caught in situations that are beyond your control over and over and over again, it takes a toll. In maintaining that care-based perspective, which we so strongly encourage and nurture here at the college, can be difficult. I saw a quote from in the New York Times, which was talking about staffing shortages. And the quote, one of the first things I'm going to talk about in staffing shortages is the use of inexperienced nurses in critical care settings. We have nurses who are on medical surgical floors that are being moved into ICU to care for critically ill patients. And this New York Times article likened it to these new inexperienced nurses being canaries in a gold mine. Now, what does that mean? That's kind of an odd saying. Well, in the olden days, miners would take a cage and put a canary deep into the mine. And if the canary survived, there was enough oxygen and it was okay for the miners to go in. If the canary didn't survive, well, you know where that's going. That's a really strange way to describe our new nurses who need more support than anybody else. Staffing shortages can also be occurring because of furloughs. Some hospitals are taking huge financial hits here, and they're furloughing non-essential nurses. We're canceling elective surgeries. We're shutting down outpatient clinics. In our part of the country, we're seeing that come back, but it's happening across the world. Nurses also sometimes decide they need a mental health day. Do 5 12-hour shifts in a row, and those are never 12-hour shifts. They're about 14-hour shifts. That's emotionally and mentally taxing. And so you decide to do the right thing to try to sort of store up on your mental health before you go in again. But most nurses just feel, I just threw my entire team under the bus because I'm not there to help. So one of the first individuals who got back to me when I asked them to describe what this has been like for you was Phoebe Oakes. Phoebe's a critical care nurse practitioner, and she's at the Elliott Hospital Intensive Care Unit, and I've gotten to know her by going in there with my students. She's amazing. And I'm going to let you read those quotes yourself. But I will say, as we go through these interviews with my peer group, a theme that emerged very quickly was the importance of team and recognizing that you're part of a team and that you can't survive without that team support. Her second quote that really resonated with me was, It's certainly taken a toll on their emotional well-being from being exposed and being afraid to expose their families, not knowing if they're bringing it home with them. And the third one was how difficult it is to care for these extremely ill patients that often are in the ICU if they recover for 1 to 2 months. And if they die, they're dying alone. The nurses have to become their families during this time. I had to put this picture in with this quote because what Phoebe said really sort of dovetailed nicely into this, that there's sort of this disbelief that in this day and age, and I'll quote the nurse here, in that window at that moment, I thought, in what lifetime would a family not be able to crowd around their loved one's bed as they died? This one. That's hard to grasp. It really is. I've been there. I've been with patients who have passed without having anyone with them. And it's amazing what the nurses do. The way we step up, the way we place our hands on that patient so someone is there with them when they pass. Rose Bunzel graduated last spring, 2019. Another amazing young woman. I had her in my critical care class and she was in my clinical group. So I was able to work directly with Rose, and she's a very bright young woman, and she was able to leave St. Anselm College and go right into the new grad residency at Mass General Hospital for the medical surgical ICU. Now, a graduate residency is about 6 months, and you are intensely trained to manage the sickest of the sick. It's Mass General after all, right? But what she shared with me about some of her experience really sort of rattled me a bit. She came off her residency just as COVID hit. So she really needed some time to sort of ramp up and take those sickest of the sick. And for you that are not in nursing, if I look at that first quote, that's an amazingly difficult assignment for a new grad. What does that mean, all those words? That means that's 2 patients who have tubes down their throats, who are 100% dependent on ventilators, who are pharmacologically sedated and paralyzed, and who we have to flip from their back onto their belly and then back every 12 hours just to get some sort of lung tissue to work. And in addition, they've got 12 different intravenous infusions going in that the nurse is titrating up and down pretty continuously to get the desired effect of that, whatever drug is infusing. And in COVID, what happens is that all those ICU pumps are outside of the patient room because you don't want to be in there with the patient. In pre-COVID, you would not want to be outside of that room. I would tell my student, you're not leaving this room today. This patient's really sick. And imagine having 2 of those patients. But Rose being Rose finds some positive things out of this too. I really loved how she talked about unity and the team spirit, and that was something she learned at St. Anselm College, that sense of community. And that this whole experience had really showed her how strong she is and how strong her team is. And speaking of team, you know you're in the right team when you can have great verbal and nonverbal communication. And I think the eyes, well, the eyes are the windows of someone's soul, correct? And I loved this quote. And I don't know if it necessarily fits here, but it deserved a place in this presentation. Because I can look across a unit and look in someone's eyes, and I can tell if it's the I'm relieved eyes, the I need help eyes, or the I'm all right, not really eyes, or I'm scared. When I started up this clinical rotation with my students, I introduced them to a nurse who's been in the ICU at the Elliott for a really long time. And she was kind of talking to them about, where are you going next? What are you going to get for a job? What are you looking for? And she gave them some wonderful advice. She said, you know, it's not about the money. It's about being in the right place. And wherever you're working, if you don't feel like those coworkers are family within 6 months, you should really rethink about where you are. Working as a nurse in a unit on a floor is a tight-knit, intimate experience. You are completely dependent on each other to make that day-night shift work. Elizabeth Benjamin, St. Anselm grad, 1986. She gave us a kind of different perspective, but I think it's a really important one. about the financial impact that COVID has had on hospitals. And she's at Winchester Hospital. She's a clinical practice specialist, so does education for the emergency services, and they were busy. And she said that they lost $150 million. And how does that happen? People are like, well, the ICUs are full. Everyone's so sick. Intensive care costs so much money. Well, not if you're not going to be making money if you're not doing elective surgeries, if you're not having outpatient clinics, if you're not doing follow-ups. And she says there's a real question about how they can still deliver quality care in these financial conditions. She also talks about the social aspect of the job. It's important. We just talked about that, and I just talked about it a few minutes ago. You really need to feel like your work is part of your family. But Liz always ends on a bright note. She says, it's an amazing time to come to the hospital. Regardless, come on, let's do this. Nursing is an art and a science. You can tell she's a St. A's grad. Taking care of a patient who's isolated from their family and who's scared has really brought out the best in all of us. This is one of my favorite sayings, and I say this to my students. Nursing is a team sport. You cannot do this by yourself. Anya Glavin graduated in May, and she was working as a nursing assistant during the peak of the pandemic at Beth Israel Deaconess Medical Center. And she really had sort of a different perspective on this. And the first quote here where she's talking about how nervous everyone was and no one knew how it was spreading and they didn't know if they were going to get it or give it to their patients, and that fear of the unknown. Man, I had a flashback to HIV and AIDS in New York City in the 1980s when I left St. Anselm College, small town New Hampshire girl in a small liberal arts college in New Hampshire, and I went to Manhattan, and it was a wonderful experience. But I do remember in the late 80s, in the mid to late 80s, when every private room at NYU Medical Center was an HIV/AIDS patient. And we were trying to do everything right, but we didn't know if we were doing everything right. And our practice evolved as our recognition of the pathology and the management of the disease evolved. And that's what's happening here with COVID. Things that we thought were right might not be the right thing in retrospect, but we were trying to do the right thing. She also talks about how nurses use their knowledge from school and practice. And no one knew the best course of action of treatment. I think that's a challenge for us with our current students and our students who are going to be graduating in the spring. There may be a real discord or a disconnect between what we're teaching and what they may see in practice, and we have to prepare them to understand that that may happen. And she too commented on the team approach and how important it was. Stephanie Joyce is a resource nurse at the ICU in the Elliott. She's also a St. A's grad. Again, the importance of team, and I will tell you the Elliott ICU team is an amazing group of men and women. She acknowledges that there are really hard days, and really hard days when you just have to make yourself go home after 14 hours. It's time to leave. It's time to leave. It's time to let somebody else carry the torch for a bit. And she acknowledged that we're doing things that we haven't done before, and that's really challenging. We're such an evidence-based practice discipline. We're not going to do something unless you give us the evidence that it's the right thing to do. And we may be doing some things that we don't have all the evidence, and that can be really challenging, really challenging. And the last woman I talked with was Karen Annan. She's a nurse at Tufts Medical Center. I call her Carrie. I worked with Carrie for a long time in the cardiothoracic unit when I was there. She's a fantastic nurse. She left ICU nursing about 5 years ago. But during COVID, she was sent back into the ICUs to work, and sort of discriminately. She wasn't in the cardiac ICU. She floated to, I think there's 5 different ICUs there, to whichever one needed her. And she described it as being back-breaking, soul-crushing work. And she's really praying that this does not happen again. And I think we're all doing the same. And she talked about how she was afraid for her patients, for her family, for her own lives, how they banded together, again, that team approach. And what she said here, that like soldiers on a battlefield, we didn't come out the same way we went in. I think that is a profound statement. She acknowledges that there was a lot of trauma caring for these patients by what they saw, what they had to do. Nobody wants to go through this again. And in addition to dealing with her own issues of trying to give good care and take care of herself, Carrie's son, Neil, is on the COVID intubation team at Tufts Medical Center. So she said every time she went to work and Neil was there too, it was just another added layer of distress. Recently in the Boston Globe, there was an article which quoted Brigadier General Jack Hammond. And Jack Hammond is the executive director of the Red Sox Foundation in Massachusetts General Home Base Program. And he's a national security fellow at Harvard University. And he does a lot of work with the military and post-traumatic stress disorder. And when he was approached to give his opinion about issues for healthcare workers during and after the pandemic, whenever that happens, he said when they have time to reflect upon some of the things that they've witnessed and experienced, that's when it's probably going to affect them the most. And I think it's easy to survive the chaos. It's when the chaos lessens that we recognize some ongoing challenges and we need to address them and have support in place for these challenges. Some of those challenges may include new decisions, actions, and expectations of care. As I said, we're firmly entrenched in evidence-based practice, but some decisions and actions may be taken that sort of contradict that evidence-based practice. It may have only been sort of discussed abstractly, theoretically, academically, but not put into practice. I loved what this woman wrote on her arm, actions you'll never find in a handbook. We're going to be rewriting some handbooks, and I would skip down to say changes in policies and procedures. The barriers to compassionate care could be profound. We see them in the acute care setting. We see them in long-term care. The elderly going weeks without seeing family. We know the importance of family. We know the importance of being around those who love you in the healing process, in the living process. It could be compassionate care, not being able to deliver compassionate care can be very frustrating and debilitating. And I found a quote from an ER physician who, on reflecting what she does in the ER on a nightly basis, she says, "This isn't what we do. You stand, you wait, time of death, 7:19 p.m. We need to make sure that there's ongoing support for healthcare providers to prevent moral distress from sort of morphing into moral injury, to recognize post-traumatic stress disorder. We want our students early on to recognize the signs and symptoms of moral distress, which can include frustration, anger, guilt. There can be physical manifestations, palpitations, insomnia, fatigue, and psychological manifestations like withdrawal from others, emotional exhaustion, depersonalization of patients. We're going to have issues with chronic disease management, and I would say that's a twofold issue. One, because of the intensity of focus on the acute care management and the intensive care management, we had to shut down, if you will, some of our ongoing preventative management of chronic diseases. A lot of outpatient clinics closed down, decreased access to primary care providers and specialists. I think we're going to see an uptick in some issues with chronic disease outside of COVID. And I think we're going to have to learn how to manage the chronic diseases that will emerge from COVID. We know that COVID is a systemic inflammatory process that hits multiple organs in the body. And we're already seeing that it has created structural and damaging and permanent changes to lung tissue, cardiac tissue, and kidney tissue. It's going to be a whole new ballgame of how to deal with these patients. Public health issues, Not in my wheelhouse, I'll be honest, but I think it's going to implode. Just look at the debate around vaccines before this even happened. Look at the debate and the consternation about developing a vaccine, the implication for public school systems, education. We're living it right now, trying to do everything right at St. Anselm College. The mental health issues that can come from living within a pandemic, being sick or not being sick, the isolation. How are we going to get people back? Are we going back? Is there a new normal? That uncertainty, there's a lot of fear out there. Healthcare equity, unfortunately, is a huge issue in this country. And we've known about this for many years. But between the pandemic and the racial justice issues in this country, it's really come to the forefront. And I would say that there is inequity in access to healthcare, in quality of healthcare, and continued preventative healthcare for many marginalized populations in this country. Again, those changes in policies and procedures, institutionally and nationally, let's keep our fingers crossed. Let's try to follow those guidelines and do the right thing and wait for those policies and procedures to evolve. And the new graduate preparation is essential. And here are some of the things that I would talk to about my current students and my new grads. Pay attention to your inner voice. Listen to your own moral compass. Recognize the conflicts. It's okay. Seek out professional and institutional resources. Go to the American Nurses Association Code of Ethics or contact the International Council of Nurses Code of Ethics. If you're working in a hospital, go to the ethics committee. Many hospitals in Boston, and we should all be very proud of the way the hospitals are treating their healthcare providers, have moral distress consulting teams already in place. Recognize those signs of moral distress that I just talked about. We need to teach our students those signs early on. Seek out a trusted mentor. It's okay to contact a qualified counselor or therapist. Lean on friends and coworkers and family. They may not understand the details of what you're going through, but they know you and they want to be there for you. Appreciate your small successes. They're important. And remember that crisis calls for excellence. It doesn't call for perfection. No one can be perfect during a crisis. As I was going through my laptop, I have pictures of every clinical group that I've ever worked with, and these are just a few. But up here in the upper left-hand corner, that's what we're looking like in the ICU at the Elliott. Not so much the white suits. These guys are on their way to the OR. But we're masking, we're face shielding, just to go into a patient's room. And in the brief time that I was gone from the end of March over the summer, a lot has changed in policies. It's sort of, even for me, a relearning of what to do. So what can we do for our students? I think focus on the importance of resiliency. We're really good about talking about that in the Department of Nursing, and we're trying to talk about it really early in the curriculum. It's important to have something in your life that can provide you some resiliency. Talk about moral distress. Help them know those signs and symptoms, what to do if you're feeling that. Let's open up those channels of postgraduate communication. I love it when my students get back in touch with me and tell me their experiences or say, hey, I was on a night shift last night and this happened, and what do you think? All HIPAA regulated, believe me. We need to address the paradox of what we teach you may not be what you actually do. That may happen that quickly, and that's okay. Nurses need to be flexible. We can learn on our feet. We'll do what we need to do to have the skills to take care of our patients. I'd also ask them to start thinking about becoming the change in the healthcare disparity issue in this country. What can we do on a local level, a national level, to right the healthcare inequity in the United States? And I would also say, Recognize the importance of being part of an interdisciplinary team. Nursing can't do everything on its own. Doctor can't do everything on its own. Respiratory therapy can't do everything on its own. It's very important that we recognize the need to work collaboratively and corroborate with our other team members. I'd like to go back to the slide, the picture on the first slide. And I want to read you the quote that accompanied it, because I think it really sort of encapsulate the challenge that comes with having a care-based practice and trying to provide that during COVID. She's 98, and the isolation and loneliness came over her in a river of tears at my visit. Not able to see her son or daughter for 6 weeks. She wants to die. Because at 98, the waiting is too much. I offered to FaceTime her son and she cried more. She wanted a real hug. I, in my PPE, said, enough. I too bent over into her arms. She wrapped so tightly around me and I broke the rule. I hugged her till she could breathe and we both had a healing. I do it again. Love matters most. Sort of a very cold segue into my reference page, but here are the references for this presentation. And I'd like to thank the Honors Lecture Series and my contributors, and certainly healthcare workers everywhere for what they're doing to provide excellent care during these really strange times in the pandemic, and for what everyone's doing to prevent the second wave so we don't have to live through this again. I'm gonna go back to the screen here and we'd be able to take some questions or discussions, whatever works for anybody. I hope you enjoyed that. So, sorry, is it possible to discuss a little more the long-term health problems, complications that people surviving hospitalization are experiencing? What long-term health problems are we aware at this point? I hope I got to that a little bit. I'm thinking right now, and not being an expert in the long-term, because I don't think we really know, but I do think we're seeing a lot of long-term poor respiratory function. People are not getting their baseline physiology back for breathing, for respiratory function. There's permanent chronic structural changes in the lungs. We're seeing a lot of issues in the myocardium, a lot of myocarditis, which is inflammation of the cardiac muscle. And we're seeing a lot of long-term renal complications. And I'm projecting, and you know, I'm not an epidemiologist, but I do think we're going to probably see issues along the ways of we don't know what's going to be happening with the immunity, the effectiveness of a vaccine, and I think we're going to be seeing that too. I'll just read these and then answer them. Is that good? Okay. So can you offer any recommendations based on your experience or experience of those with whom you've spoken on remedies for social injustice, like vulnerability and access to care for those marginalized in our communities, e.g. people of color, aged, those with pre-existing conditions? I wish I had a pad answer for that, Mark, and Mark Regani from the college. You know, it's been around a long time, and I think as horrible as the world has been, it's been a necessary sort of event to open up our eyes. I mean, it's people of color, it's people, the elderly, as you've said, pre-existing conditions, conditions that we're not even sure are being affected by COVID. It's the mental health issues. It's people with substance misuse disorder. We have to find a way to give them access of care and equal quality of care. And I don't have an answer for that. Would love to talk to you about it. at another time, but it's something that I think is going to get worse in this country right now. Is it okay for nurses and nursing students to cry? Yes. I have sat in post-conference with my students and will cry. I have sat in my car after a shift and I've cried. And the time that I had to stand at a person's bedside without family and hold his hand as he cries, as he dies, I cried too. I mean, we're human beings. We're compassionate human beings, and we're trying to provide compassionate care. And if that doesn't move you emotionally, then you need to think about things. I think it's totally okay to cry, and it's totally okay not to cry. Thank you, Deb McCarter. Let's see, how do we work collaboratively even outside the hospital setting? We're all in this together, but for example, it's been extremely hard to convince everyone that wearing masks is essential. How do we support one another? I watch the news, or I go on it and I read the news on the computer, and I just shake my head in wonderment. I don't understand. I'm not going to get into politics. Nobody wants to get into politics, right? But I think, there has been an impact of politics on the way that we're trying to manage this. And let's stick to the science. I mean, science is proving that wearing a mask can decrease the transmission. And if you don't want to do it for somebody else, you should be doing it for yourself. I think we're doing a great job on the Hilltop right now, we worked hard to get our students back, and we're working hard to keep them there. And that requires respect for self and respect for others. And I hope that would be enough. I think we're trying to do everything to educate the public in general about what they need to do. But there seems to be this individual over the collective mentality that is really harming our progress in containing this. Thank you to Abigail Connaughton. Do you think the pandemic will change the way that colleges set up nursing programs in the future? That is a fantastic question, and I do. I think it's sort of changing what we're doing now, and maybe it's an on-the-fly sort of change, but I think we're going to have to really start having a higher dependency on technology. We're so very fortunate that the nursing institutions, our healthcare organizations, allowed our students back in. We need to keep having that clinical experience. We might just see an increased use of simulation to provide that clinical experience. It might open new doors and new avenues and new environments for clinical experiences too. I think it might also change the way a new graduate is accepted into the hospital. I think we're going to see a lot more residency programs to really produce a nurse that's sort of ready to hit the ground running after 6 months. Because we always say it takes a while. You're going to be very book knowledgeable when you leave the college, but you need to get some experiential knowledge too. An alum. She works in the SICU at late. I'm just glancing through this. All right, so we have an alum from the class of 2014 who works in the surgical ICU at Leahy Clinic. And she shares with me that she's found that journaling has really helped her sort of reflect upon, I don't mean to speak for you, Erin, but I'm assuming help you reflect upon what you've experienced while taking care of COVID patients. We use a lot of journaling here at the college. My students write 1 or 2 journals every week about their experiences taking care of patients in the ICU. And it's a really great reflective tool to gain a better understanding of not so much reflecting at, but upon the experience of the day. Have a question about we're running clinicals. That's really sort of different between different specialties. In the ICU, we're back in there full force. We intentionally have contracted not to take care of any COVID positive patients. But for the most part, we follow the institutional guidelines, and our students are back in there. And there are some restrictions, but that's usually based on the healthcare organization rather than the college itself. What is the biggest lesson you have learned both as a nurse and a human being throughout this pandemic? That's a great question. I've learned to appreciate life a lot more as a human being. I've learned to appreciate my friends, my family. I've learned to appreciate my education that's allowed me to understand maybe on a deeper level what's happening. As a nurse, it makes me appreciate my discipline, that I can walk into the ICU and I know I can turn to anybody there and they have my back. And I think what we do as nurses is amazing. We are the first ones at the bedside to pick up those subtle changes that can lead to huge changes in someone's clinical status. And I'm proud of what I do every day as a nurse. Do you think graduating nursing classes will burn out more quickly in the next few years? God, I hope not. I hope not. I hope we're doing something right that's going to help you recognize when you're starting to struggle early on. You know, I didn't have that as a new grad. I was that, and not so much from the college, but from the work environment. It's like, oh, leave it at the door. You're fine. Go home to your apartment in New York City. You can't drop it at the door. If you have a long ride home, you think about your patients. You think more about things maybe you should have done than everything you did right. So again, I'm hoping that new nurses can really hold on to those small successes and be good to themselves. What advantage do you believe nursing students are getting, especially the students worldwide just starting their education? Well, honestly, I think it's a wonderful profession. And I think that having that higher knowledge level or deeper knowledge level, like I was just talking about, really will get you through something like the pandemic. It'll help you have a better understanding of the guidelines and the requirements that are being asked of you. And the nursing students worldwide, I honestly really can only speak to the States. I'm not that familiar with the educational systems outside of the United States, but I can only imagine that they're trying to do the same thing, to prepare their students to be ready for a lot of changes and prepare their students to take good care of themselves. With the mental toll that COVID has taken on nurses working and how it has affected everyone emotionally, do you feel as though it should be focused on more throughout nursing school as well? I think it's a very important focus, and that's a great question. And I think that sort of dovetails nicely in what I'm talking about. We have a rather unique perspective on the mental health component in nursing. A lot of programs will have, this is your mental health class, you do a clinical. We do have mental health nursing, but the remainder of the curriculum, we pull threads of mental health and mental wellness through all other courses and clinical experiences. And recently, recently went through an accreditation process, and it's a pretty unique way to present teaching mental health and encouraging mental health. And we actually were really praised, the program was praised for the way that we're addressing the mental health component of nursing. I think that's the last question. Anything else? I'm going to turn this back over to Dr. Holder. I appreciate your questions. I hope you enjoyed the presentation. Feel free to look me up on the college website if you have any other questions at all. I'm very, very happy to dialogue with you about it. We can email or Zoom or whatever. So here we go. Here's Dr. Holder.
So first, just what a great presentation. Thank you so much, Dr. MacLeod. This was a fantastic beginning to this year's lecture series, and something that is so meaningful, so has touched so many people's lives and continues to. So thank you, and thank you for the work you do with your students. I want to tell the audience our next honors lecture series lecture is already set. It will be Dr. Jennifer Pace from the chemistry department speaking about the, this is a general topic, not her actual title, but the topic is the science of COVID-19. And that will be October 1st. And again, it will be in a webinar setting. So we would love to have you and as many other people. We think this is a service to the community. We want to be giving this knowledge away. Right now, once again, thank you, Dr. MacLeod, and thank you to our IT department that makes this all possible. Thanks so much for coming out, and I look forward to seeing you again, both in webinars and someday on the hilltop. Take care.